Dr. Kigonda, I think we are good to go.
Thank you. Thank you, Peter. Welcome everyone to this very exciting webinar. The Kenya Medical Association is very strong on continuous professional education, and I think that is one of our core businesses as a professional medical association. We normally work with like-minded partners who engage our members to come up with very informative topics that are relevant to the practice of medicine for the majority of all of us. Today, we are happy to partner with Novartis, and with us, we have one of our members, who is Dr. Mativo, and his team, to take us through a very interesting disease component that is probably very difficult for majority of us, poorly understood, but can only be brought out by a specialist deep inside the nervous system. I want to welcome you all to register as Kenya Medical Association members and be active members in our committees. And with that, I want to welcome the team from Novartis to take us through the program. Thank you very much.
Thank you. This is Dr. Mativo, and I'm proud that and kind for the kind introduction. We'll go through why we need to prevent migraine. While we always talk about abortive treatment, and we usually talk about abortive treatment and preventive treatment, but we have never asked ourselves why. Why do we need to bother to give prophylaxis of migraine headache? And that is the topic I was asked to be shared. Okay, I have a disclaimer. My preparation is not anything to associated with Novartis, and this is my personal preparation, and I've never had a topic of such a kind before. Thank you. Therefore, I hope what I've prepared will be very exciting. Now, what is migraine? It's a very severe headache. It can be, is a thrombing, usually unilateral. Migraine word, which comes from migraine, is a French word which means half head. Therefore, usually migraine is unilateral, but it can be bilateral, can be global. And this headache usually should last more than 4 hours or more, usually between 4, and I've always have seen patients who go even up to 7 days on migraine treatment, on migraine headache. Some of the headache is worsened by physical activity, bright light, loud noise, and strong odor. Remember, migraine is very destructive to human life. It interferes with your routine, daily routines, and the ability to meet even personal and social obligations. And that is actually why we need to make the patient's life better, most of their life. We might not be talking of cure. Migraine, women, it accounts about 20 to 25% of women will suffer migraine headache. Around 5 to 8% of men suffer migraine headache. And this is possibly because of our hormonal differences, estrogen versus testosterone. Usually migraine...
I think slides are not moving. I don't know whether it's only me. Peter, are the slides moving? Yeah, maybe put it in, yeah, that's better. That's better. That's fine. Thank you. I think you can continue.
Okay, thank you. Migraine, of the previous slide, I had said migraine, the prevalence increases until age of 40. Usually, onset of migraine is between the age of 12 to 40. And that prevalence decreases after that. And most women, migraine improves after they reach menopause. Migraine, 1 year prevalence of migraine in women is around 18%, and for men is around 9%. In 2019, migraine was the second most cause of disability in the disease profile, and most important disability in women less than 50 years of age. Therefore, at that age is actually the most reproductive age of human life, and always they are complaining of migraine. 40% of patients who suffer migraine will have chronic migraine and will benefit from preventive treatment. Only around 3 to 13% of patients who really require preventive treatment are on preventive drugs. Adherence over time, patients actually is very low. Patients, when their headache stops, and you bear me witness, they usually stop their medication and say they are cured. Therefore, that is a big problem. Adherence is low. What is this definition of prophylaxis? Prophylaxis is a treatment or a modality or medications which are used to prevent episodes of migraine happening. And this, as we say, the recurrent migraines cause a lot of functional disability, and they also impair the quality of life of patients. And preventive medications, these are for migraine, there are strategies which work to reduce frequency, severity, and duration of these migraine attacks. Two, they also improve responsiveness of the acute medication, or what we call abortive treatment. That is the painkiller patients use. If you look very well and you listen to the patients, they will tell you initially they were taking Panadol to work. They stopped having that. They went to ibuprofen. They went to diclofenac. There is that desensitization of drugs in migraine. And when you use preventive treatment, you get sensitization. Therefore, the drugs we stopped working start working again. The other prevention drugs can also be very important because they are used in other health issues. Like drugs for migraine, which we use, can be used. Some of them are blood pressure drugs. Some of them are for depression. Some of them help in sleep. Some of them even are epileptic drugs. Therefore, they can be used in treatment for other things except just the headache. Now, when we prevent our migraine, it reduces disability to the patients, and it also reduces the frequency and the utilization of abortive treatments. And then it also lowers the cost of migraine management, because that is a cost every time they are rushing. And patients will tell you they have a chemist where they go and pick painkillers. This is not me alone, but most of us who practice, the patients always tell you that. And these preventive treatment approaches as a combination, we can use prescribed drugs or non-prescribed medication, natural supplements, vitamins like riboflavin, minerals, lifestyle changes, because most of them is a genetic condition. Migraine is a genetic condition, but triggered by environmental. Therefore, lifestyle changes is important in prevention. Therefore, migraine headaches are associated with one, significant headache pain. Two, they have a disability of functional impairment. Three, patients have the reduced quality of life. And sometimes these patients, when they get sudden headaches, it disrupts their plans, their work, or even participating in their usual activities. Therefore, it can impair their life, as migraine can come and then They are not able to attend to their work or plans, or they can't even arrange their life. That is why we need to reduce their suffering. 85% of migraineurs who live with their partners, they have there is a substantial reduction of ability to do household work. And that's a very big number, 85%. And remember, 20 to 25% of all women suffer from migraine. And 45% are forced to miss social, family, and leisure activities because of headache. Therefore, that is how much migraine affects humanity. And that now that 2% avoid making plans for fear of cancellation, because as I said, migraine can be sudden onset. Therefore, they don't even want to make plans because they fear to canceling plans of their day because of migraine attacks. And 50% believed more likely to argue with their partners and children, and they don't have, they are reported to have a negative influence of the disorder on their time spent with their children and the family. Therefore, you can see how much family cohesion is affected. Therefore, migraine being one of the major disabilities, we need to do something to prevent it. As we say that around 38 to 40% of patients who suffer migraine should have a preventive treatment. 3 to 13% of the sufferers, as I said, they are actually on treatment. But overuse of abortive medication can cause rebound headache. And that's what we call painkiller withdrawal headache. You find patients who have been using painkiller, they can't manage to stop, even after starting preventive treatment, because they get a rebound headache, purely because there's central sensitization of this pain control. And that is why they can't come down on the painkillers. The importance of migraine prophylaxis is one, as I said, we decrease frequency, severity, duration of migraine attacks, responsiveness of acute treatment, and improve quality of life. And we also avoid migraine headache complications. Migraine is not just a headache, it has also its complications, and we need to help them avoid complications. Now, migraine affects the whole body. It's not going to affect only the head. Like the head, you'll get patients will have depression, anxiety, they'll have memory lapses because they lose attention, and they lack difficulty in concentration. Therefore, the patients might be said, the patient is, most patients will come you with, who you have they have visited you, they'll say, you know, I'm having memory loss, but purely because attention is affected by migraine. It also affects EIX, it also have visual impairment, gastrointestinal complications, you have frequent urinations, you have dizziness, they have temporary paralysis like in hemiplegic migraine headache, where a patient will come, one side is weak, we think it is a stroke, even others have been thrombolized. They have numbness, tingling sensation, hot heat flashes, yawning, joint pains. Migraine affects the whole body, it's not just purely the head. The migraine attacks are usually associated with the central neuronal activation. And this is a trigeminal vascular system. And cortical spreading the activation or brainstem generator. And then this medicine which we use to prevent migraine, they inhibit cortical spreading depression, which is more defined and characterized in patients with aura. They do blocking of calcium and sodium channels, blocking of gap junctions, and they inhibit matrix metalloproteinases, and during these acute migraine attacks. And this is how the migraine has 4 stages of It can just four stages. There's prodromal, there is aura, there is the headache itself, and the postdromal. Prodromal, patients will tell you before migraine up to hours to several days, they are fatigued, they lose concentration, they are irritable, yawning, they are craving, phonophobia. During the aura can be motor, sensory, visual, mixed auras. They can have, during the headache, usually it's a throbbing, pulsating headache, can be unilateral, bilateral, or global. It's associated usually with nausea or vomiting, photophobia, phonophobia, kynosophobia, osmophobia during the acute attacks, and it's worse with activity during that time. Therefore, patients will withdraw, and that also make sure it helps you to differentiate between migraine and cluster, because migraine headache was during activity. Cluster headache patients are restless. Therefore, that helps you to differentiate between the two. And then postdromal phase, which occurs, this can last up to 24 hours, what we call migraine hangovers. It can involve many things, which I'll talk later: fatigue, concentration, depression, irritability. Therefore, that is a pattern of how migraine develops. Now, there are also episodic syndromes that may be associated with migraine. Patients who can have what we call abdominal migraine headache. They have abdominal pains, discomfort, nausea, vomiting. That can also lead you to dehydration, malnutrition. These are all associated with migraine. Others come with vertigo, dizziness, what we call vestibular migraine headaches. They come with a very severe dizziness. Others have torticollis, where they turn head tilt on one side. And this, what we call benign torticollis, this is a presentation which we see in less than age of 3 years in children, where they turn head tilt on one side. But that is not only in children less than 3 years. Children between 3 years and 10 years, they have what we call abdominal migraine headaches. Then we have migraine can also be refractory to treatment or can be resistant. Refractory is typical, whereby it's characterized by 8 monthly days of debilitating headaches, which are inadequately responsive and intolerant, or contraindication to 3 or more preventive classes of drugs. The resistant migraine is mostly results from drug failure. Refractory migraine, we don't know the mechanism, and we don't know what impairs failure of treatment. Therefore, there are those cases we might not be able to actually solve their headache. Resistant migraine can be treated with specific migraine headaches, just because it's a failure of drug use, failure of drugs, and not like refractory. Therefore, they still have drugs to respond to. Headache Federation in 2020, it's also defined the same things. It's a failure of 3 or more classes of preventive drugs for resistant migraine, and failure of all classes of preventive drugs to define them as refractory. Individuals, and you look at the treatments, patients who have resistant migraine, we are seeing, usually you'd see them around 13% in a general primary care, which most of us do, or neurology. In more specialized care, where there is interest in care, they'll get around 48% of resistant headaches. In physicians with headache specialists, centers, they have a higher percentage of getting resistant headache, which is around 75%. And that also occurs with the refractory headaches, whereby around 8% with the primary general care or neurologist, around 23% in special interest in headache care centers, and around 46% in physician in headache specialist centers. Therefore, this is what we need to avoid by doing early preventions. Now, how do we avoid refractory headache? I'm very sure some of these things most of us have not heard of them. One is to have a regular sleeping and eating pattern. Therefore, you must have a sleep hygiene. Eating has to have a regular pattern. And as we know, hunger can trigger migraine headache. Therefore, they must have a regular eating pattern. Exercise has to be regular, and usually anaerobic exercise treats migraines. Aerobic might trigger migraines, but therefore, aerobics are slow in speed. Anaerobic is like running 100 meters. That is very fast in speed. Just can trigger migraine. Food diaries, there are some food which can trigger migraine. Therefore, chocolate, caffeine, alcohol, drinks. Therefore, they need to have a diary to know which foods trigger their headache and how they should avoid them. Therefore, they also need to have what we call relaxation techniques, whereby we manage their stress through cognitive behavioral therapy, relaxation techniques. Now, what we call postdromal stage of migraine, which is migraine hangover, is actually a time where the patients feel tired, they feel sore and fog, and that can last up to 48 hours. Postdrom in experts, they believe it occurs in around 80%, but not always. But postdromal phase, you can see how common it is, up to 80%, but that is an expert opinion. Some of the hangovers patients go through, that is postdromal phase, they lose their concentration, they're always feeling tired, they have low mood, bad mood, they feel drained, they have gastrointestinal symptoms, which you had said, they feel discomfort of the stomach, they can have vomiting, they are weak, their neck is stiff, they are sensitive, they are becoming photophobia, and they have nausea. These symptoms lasting up to 48 hours. This is a big disability to these patients. The 48 hours is too long. Those are 2 days. These are the same symptoms, as I say. Some will have some mild headache, they're feeling very hungry, thirsty, as I said, mood change, some of them become euphoric, and they are full of energy. Therefore, every presentation is a different person, and they need to have a diary to know their postdromal phase. How do we manage the postdromal or migraine hangovers? Encourage your patients to drink a lot of water. Dehydration or thirst actually triggers migraine. Encourage them to have a regular sleeping and eating pattern, that is good rest. Relaxation activities like yoga. Yoga is an aerobic, that is a slow activity. Ice baths, you can use eating pads, massage, stretching. And I said you need to have a headache diary. These patients will know the prodromal phase of migraine hangovers and what works for them. And what works in one doesn't mean everybody will work with them. Therefore, what works, it does not mean someone else will necessarily have to work. Therefore, that is why you encourage your patients to have a diary. Some of the prevention of migraine, as we said, is you have a regular sleeping. Migraine hangover, they must have a good sleep habits. They must have a regular eating and healthy food. Exercise helps. Stress management care helps. They need to avoid triggers and treat the pain as soon as it starts. You don't wait the pain to be very severe. Actually, usually it's at the beginning when the pain is starting to peak. That's actually when you are supposed to use painkiller. Therefore, we treat early as possible at the time the headache is starting. There are migraine management, then there are 4 things we do. 1, avoid triggers. Therefore, ask the patients their triggers. Each person has their own triggers. You need to have lifestyle modification. As I said, is a genetic condition triggered by environment. Therefore, the environmental triggers, which are possible to be identified and avoided, encourage the patients to do that. There are non-pharmacological treatments and medications which we use, which we are going to discuss, but the next few slides. Some of the triggers could be light, could be noise, could be menses, could be all smells, could be hormonal drug, hormonal medication like contraceptive, hormone replacement therapies, could be foods like cheese, wine, that is alcohol, and sleep deprivation or oversleeping can also trigger. Therefore, some of these things are, that list is a small list for the triggers. Now, when we think of prophylaxis, pharmacological prophylaxis, if the headache is recurring to a point it's disabling a patient, it's a daily routine despite acute treatments, or it's recurring too much to disable. It's also having impairment of quality of life, business duties, school. Therefore, quality of life, you also need to think about preventive treatment. If a headache is more than 1 day in a week, this is four attacks in a month, but in US guideline is 2 or more in a month. When you have acute medication failure or abortive treatment failure, and as I said, we have what we call desensitization. And also abortive treatment have contraindication. If someone has peptic ulcer disease, they cannot take painkillers, NSAIDs, and possibly already they have desensitization of the others. 2, they also, as I said, ineffective, overused, and if they cannot be tolerated by the patient, therefore you need to start. And the patients can also tell you, these headaches, I think I need to be prevented. Therefore, preference of a patient should be respected. When the hours are too long, okay, it's uncomfortable. Other headache, migraine headache conditions, and which are like hemiplegic migraine, basilar type of migraine, which presents with a lot of dizziness, and prolonged hours with migraine as infants. Those are indications for preventive treatments. Now, the complications of migraine, because this is the reason why we need to prevent migraine, is to avoid also complications. Status migrainosus is defined by headache lasting more than 72 hours. Migrainous infarcts, these are infarcts which occur during an hour. But that time there is 1 or 2 hours they can have an neuroimaging which shows an infarct. Migralepsy is a seizure which occurred during, which is aura triggered seizure. Persistent aura is without infarction. This is an aura which lasts more than 7 days, a week, and there is no evidence of infarct or injury to the brain with a neuroimaging. Work disability, they go to work and the patients are actually go home and they can't continue working. That is something you have seen. Others, they lose work. They just decide not to work because they can't even manage. There is a mental health conditions which occur, which are associated like depression, anxiety. Medication overuse headache because of when we allow our patient to use abortive therapy, when they get rebound headache, which is medication withdrawal headache. Caffeine is one of the chemicals in this tablet called Maramoja or ephedrine. That's in America. Can also give you headaches, rebound headaches, because of using a lot of painkiller. As I say, these are the definitions: status migrainosus, 72 hours headache without, which is debilitating. Persistent aura, as I said, is more than a week, but neuroimaging is normal. There is no evidence of infarct. Migraine has infarct where you have an aura 1 or 2, and then there is an infarct. And megalepsy, which is a seizure which occurs during a migraine aura. And hemiplegic migraine, whereby the patient presents like an acute stroke or a TIA. Some of these things I think we have seen. The mental complications, they are there, but they have been shown to have been increased by migraine headache, like depression, anxiety, bipolar, panic attacks, substance overuse, agoraphobia, post-traumatic stress disorder. Therefore, there's a lot of these conditions are even, they are shown to have some increase in the migraine, increases their risk. Therefore, we need to prevent this migraine so that we don't get these complications. Some of these things we had said, the last two points is migraine without twice a week of every stroke, without have a twice risk of stroke. Therefore, that is an increase of stroke with migraine without. And the risk of stroke is also higher if you have migraine patient taking oral contraceptives. Therefore, the last two, those are the new slides in that, new points in that slide. We talked about these gastrointestinal symptoms, abdominal migraine, cyclic vomiting, vertigo, and we can also develop serotonin syndrome. This is because of use of abortive treatment like triptans, SSRIs. This can cause serotonin level to rise, and we are risking the patient to get serotonin syndrome. I've seen patients telling me they have been on triptans for their headache as preventive, and that is a risk. We can develop serotonin syndrome. Therefore, prevention is better than abortive. And this is just a graphic presentation of the complications. We say that mental changes, depression, anxiety, sleepiness. They can't sleep. Patients will tell you, I've not been able to sleep because of headache. They have vertigo, rebound headache from painkiller overuse. Ulcers, this is very common in our setup. Patients have painkiller overuse. Therefore, they come with peptic ulcer disease in the gastroenterology clinic. They are complaining of epigastric pain, strokes, as we had said, difficulty in breathing and numbness. So these are just a graphic picture of the complications. How do we manage non-pharmacological therapies? They might not go so much in detail, but these are things we can try. One first thing is avoid triggers. Always ask patients of their triggers so that and help them to know this is how they can assist. You can assist them to avoid the triggers. Relaxation techniques, that mental stress, acupunctures, these are not well published. To say they are definitive treatment, they can do massage, as we said, cognitive behavioral therapy, biofeedbacks, and trachytenius electrical nerve stimulations have been used, and these are non-pharmacological mode of migraine prevention. Now, non-pharmacological, this is also graphic. There's, we say, treatment options here is the needs are varied. They need to know triggers and need to know what actually they do to take care of their migraine headache and post-traumatic migraine hangovers. As we talked about hydration, sleeping pattern, exercise, anaerobic tend to treat aerobic trigger. They need to avoid medication overuse. If patients can be able to take medication, painkiller less than 3 days in a week, that is our actually wish. They should take less than 3 days in a week painkiller if they have to use. As we talk about supplements and minerals, magnesium is a magnesium riboflavin that we tried coenzyme Q10. This is a non-pharmacological treatment. Pharmacological medications or preventive treatment. We have just this is a list. Most drugs are in high. Some drugs come from high blood pressure medication. Beta blockers, we use them a lot, and therefore patients with migraine sometimes you might decide to use a beta blocker, and which will cover migraine and the blood pressure, and avoid calcium channel block inhibitors, except flunarizine and the verapamil. Those two can be used in migraine preventive treatment. Calcium channel blockers, actually their side effect is headache, except those two. And there are anesthesia medication. There are many which actually act on migraine. Calcitonin related peptide. Thanks, currently we have Erenumab in our market, which they call it Basuta. Therefore, this is a new kid in the block. Antidepressants, and we know the first drugs which we know they are very effective are amitriptyline, supplements which you have talked there. Neuromodulation devices, these are electrical currents or magnets which are being used. Neurotoxin is like botulinum toxin, can be used to prevent migraine headache, and Greater Hospital nerve block is picking up, and this will Greater Hospital nerve block or gone block, it will be preferred. We prefer it because there is no study to say there is any safety of migraine treatment, other migraine preventive treatment in pregnancy. It will be a very good one for pregnant patients who have migraine headaches. We tend to use now Greater Hospital nerve block because it's a local administration of a block at the Greater Hospital nerve. And these are some of the medication list which we have said antidepressants, that's level A, level B, and level C. And I think you can look at the list, sodium valproate, pyramid, all these things are there. Magnesium, Diamox. Diamox, we use it in menses, catamenial migraine headache. Even magnesium now is available. We can also use in catamenial migraine headache. At that time, also catamenial migraine headache, actually it's a big problem. Sometimes you can allow patients, if they are not responding to acetazolamide or magnesium, you might be forced to allow them to use some painkiller. These two drugs are given 2 days before healing until 2 days after the menses, and that helps you to prevent migraine during catamenial migraine headache. This is a group of drugs which have first line, which are established. As we talked about valproate, divalproates, beta blockers, and the epileptic drug pyramid, beta blockers, calcitonin-related peptide, gone block, and botulinum toxins. Others which are second base, they can be used. Atenolol, nadolol, and nadolol, which are beta blockers, antidepressant, and amitriptyline, naratriptan, then lafaxine, sembotriptan. Possibly they are effective. Cananastan, there is a possibility this is antihypertensive. Tegretol, these are drugs we try, but most of them they might be possible, but they don't give a good outcomes at the end of the day. And our drugs with a bit of questionable effects. That is some of the list of migraine headache. No. Ineffective drugs, the other ones of spermazepine, tamsulosin, lamotrigine, or now, the FDA approved calcitonin-related peptide antagonist. This is a new kid on the block and more specific to migraine treatment. These are already approved worldwide. What we have in the country is Erenumab. We used initially to import it from England for the patient, iMovie. The other one, which is currently a Pasuta. The others are Mesomab, Dalzanemzumab, Epitelimumab, Remepegand, and Atopepand. Those are a group of calcitonin-integrated peptides. Some are oral, others we are still using as injectable. Now, why should we use approved drugs? Because they have been determined, the benefits outweigh the risks. Therefore, there is evidence which can be used to say, yes, this drug has been shown to be effective. Therefore, try and use FDA-approved medication. Off-label, there is no one. It is a doctor's choice, but there is no. You can't verify the cons or pros of the drug, and that is there is more reason to be cautious with off-label because there is no approval and no any study or beneficial study which has been published. Remember, prophylactic treatment is not curative. And most patients might need abortive medication. Sometimes when you start the preventive treatment, it takes some time for the patient, even the headache to stop. Therefore, in between, as the headache is improving, advise the patient to take only painkiller when necessary, but you might need some painkiller as the headache is improving initially. And it's imperative to evaluate if patients are using the proper and adequate abortive therapies and how frequent they are, and try and encourage them to avoid because they can get rebound headache from abortive treatment. Therefore, this is something I had said before. You need to determine the frequency duration when you are talking about treatment, frequent duration and severity of the migraine headache. As we said, it's only 40% who might benefit from preventive treatment. And get all the triggers which a patient might be. Patient might tell you there is none, but you ask them, if you don't sleep well, you get headache. Yes, then they tell yes, they get headache. Therefore, patients in their mind, they believe there is nothing triggers their headache, but you have to be inquisitive. Ask them to maintain a diary, and they use preventive. Preventive drug therapy may not be needed if triggers can be identified and modified. And that is the issue here is, remember we say 40%, 60% you might deal with the triggers, they are just episodic migraine. Episodic migraine will avoid triggers and painkiller when necessary, and try and avoid painkiller more than 3 days in a week. But remember, as we said, headache more than 1 day in a week should be prevented. And then after we start preventive treatment, it is not immediate, and you need around 2 to 3 months to try a drug, and you can actually say a drug has failed if there is no change after 6 months. And the teaching is we start low dose and titrate upwards. One, there is a lot of side effects with this medication we have listed. An example, the amitriptyline I give you today, you might not even be able to wake up and work the next day. Therefore, start low dose and titrate upwards. Preference is monotherapy. Usually, we evaluate the medications and our guidelines are not strict medical guidelines to say you take preventive treatment for 1 year. They're actually pushed by European insurance companies where they say we don't cover more than 1 year if a patient is on a drug. Therefore, that pushed us to have a limit of 1 year on treatment, but it's not, there's no study to say yes, this is a guideline. Most of us, we might not successfully prevent 100% of headache, but there's a lot of benefit if we manage more than 50% of the headache. But we still struggle for better outcomes, but a successful therapy is defined by reduction by more than 50% in terms of the headache attack severity. And remember, migraine, the most important is intensity, not frequency. You can have frequent mild headache, but it's not intense, you can be functional. But when the intensity is high, and regardless, you'll be disabled, you'll be not functional. Therefore, try and look at intensity. When you are doing a follow-up in the clinics, try and look at how much the intensity has been reduced, because that will also imply about the benefit the patient has gained, one in terms of work, disability, quality of life. Most patients might be with a mild headache, they can say it's a background headache. And this is a logarithm pain preventive management. First is the triggers. Sleep pattern should be regular. Weight gain. Here we need weight loss. Weight gain, you know, when you gain weight, you have increased estrogen, and that can also give you another headache, intracranial hypertension headache. And estrogen, when it's elevated, can also be, as we talked about, contraceptives can trigger migraine headaches. Patients need to have exercise relaxation techniques, and they must also treat early migraine, treat the headache as it starts and prevent it early. Then, as I said, avoid painkiller overuse, because abortive treatment might trigger rebound headaches. And preventive medication you initiate, and you can assess their effectiveness every 3 months. If they are not effective in 6 months, that drug has to be changed. Therefore, I hope this is a new question I was asked to present. I hope I've covered what the reason why we need to treat early and prevent migraine headache early. Thank you. Any question?
Thank you, Matibo. Thank you very much. You have access to the chat. Let's have a look and see whether the chat has questions. The Q&A section. But excellent presentation.
Okay, the issue of CBT points, the Novartis will address, and the question about migraine dementia, migraine cognitive impairment. If you remember, what migraine headache has is affect attention. Attention is the first step for you to develop memory. Like now you are listening to me, therefore you are attending. If I distract you with a pain, there is no way you will concentrate on what someone else is giving you instruction. And that is how it affects memory. Therefore, there is no way migraine is not associated with dementia and cognitive deficit. It only affects attention and concentration, and that the patient will think it's memory loss, but it's not a dementing illness. And as I said, the recommendation about prophylaxis are not medical-based studies. Is actually insurance-based. The insurance in Europe, European insurance, say they can't continue treating my patients after 1 year. Therefore, the guideline of 1 year is nothing to do with medicine. It's actually to do with the pressure from insurance in the Europe. Calcitonin, there is a question about availability. As I said, Erenumab before it We used to import it as Amovic, but currently we have the same Erenumab in Kenya called Pasuta. And the Pasuta, I think the Novartis will explain how you can get it in the markets. Therefore, the issue, it is available, and I think it's just a matter of what they are going to present, how you can manage to get it in the market. But the Pasuta is available. And personally, I've used it and I've had good results. But one thing is precaution. I've had with the Erenumab is you don't think it's a shot when a patient, you give them the Erenumab, they think tomorrow I don't have my headache. Usually continue with other preventive medication for around 2 months. That's when the effect of the Erenumab, which is calcitonin-related peptide, will come on board. Therefore, do not think it's a shot. Immediately I get a shot, the patient will not have a headache. That is not true. Continue with other medication and taper it off within 2 to 3 months. Pasuta will have 15 and you continue with it monthly. And Pasuta, you start with 70 milligrams. It's a subcutaneous, it can be administered by the patient. And if the headache is not responding, we can go to 140 milligrams. Instead of, can go up to 140 milligrams. The only thing in this market, we don't have 140, and 140 outside there, the price is the same as 70 milligrams. Therefore, there is no difference. But in Kenya, because we don't have 140, you have to get two injections of 70, and that is double the price. But the costing, availability, the Novartis will talk about. Acupunctures, these are non-pharmacological forms of treatment. We don't have enough applications to say they are useful and how they work. But we don't know how they work. It may be a psychological issue, we don't know.
Thank you, Matibo. I'm looking for the Novartis representative. He's around.
Good evening, Doc. I am around.
Excellent. There was a question about availability. Are you able to take that?
Yes, so the molecule is available in Kenya. We do have our brand teams who are able to give more information with regards to pricing and everything related to that, but it is readily available in Kenya.
Fantastic. We're checking, are there any other questions on the chat box?
And use the first line.
There seems to be another question, yeah.
Usually, as you remember, we said we try. Right now, let me be clear. Right now, you can go straight away to the new drugs, calcitonin-related peptide. There is evidence that even if you start with them at the beginning, there is no problem. But the previous teachings where we tried at least 3 to 6 months with other preventive treatment, which are most of them are tablets. If they fail, then we move to 3 to 6 months, we move to the calcitonin-related peptide or other forms of treatment. But definitely today, there is that evidence that you can, from beginning, start with calcitonin-related peptide.
Excellent. I do not see any other questions in the Q&A. Okay. Very good.
I just had one quick question actually for Dr. Madivo, if possible.
Yes, Ms.
Yes, Doc, so with regards to oral agents, how have you seen the adherence levels with patients who are currently on oral agents for prophylaxis? Are there issues with adherence or anything like that, or are they able to stay on those treatments for as long as they've been prescribed to them?
Thank you, but thank you. As you remember, one of my slides, I said 3 to 13% of patients are the ones in treatment, and there's a low adherence rate from that publication. The reason is one, the patients, as I said, they feel they are cured, and it is very low. Even in our setup, we have always to plead with the patients to continue taking. Like now, I have a patient who would prefer 1 monthly injection, which is now the Pashuka or Relima, purely because he feels he will be it's unlikely that he's going to be compliant. Therefore, compliance is a big thing, especially when the headache has stopped. Most patients in Kenya, I think, they'll just disappear. After the headache has stopped, 3 months, they have disappeared. And then by next year, you find that they come back and say, I've gotten my headache back. Therefore, it's very low, even in publication, it's very low. But the injectables which you take monthly, that adherence will be better because it's once in a month. And I expect that to be better. Thank you. Then there is a question about preference of abortive treatment. One, each patient has a different benefit from each abortive treatment. And I will give you an example. We have paracetamol injection. Paracetamol is a preference, which is a powder kind, and a paracetamol tablet. Migraine patients, by the way, you'll be shocked. You can give a patient tablet, it works, but to give them injection or the powder, it doesn't work. Therefore, you can't predict which is the best abortive treatment for a patient. But one thing is, as I said, there is desensitization, and that will help you to even select the drugs which are desensitized already. They will tell you, I've used Panadol, it stopped working, I've used ibuprofen, I've used diclofenac, therefore the patients will tell you what is not working, but it's you to decide now, these ones are not working, you don't need to repeat them. Because if you repeat, they will never work until they are sensitized by preventive treatment. When you give preventive treatment, it sensitizes those acute adaptive treatment, they start working. That is the advantage of preventive treatment. You start seeing even paracetamol starts working, ibuprofen. Therefore, that's number one. Number two, triptans, there's no problem with the issue of triptan. Triptan is a painkiller. The only thing with it is there are 2 types which are you can use by nasal spray, Zomaltritan and Sumatritan. In Kenya, we have the nasal spray of Zomaltritan. The same thing happens with triptans. If one triptan works or it stops working, you can change to another triptan. Therefore, in migraine, you can't set up and say one triptan has stopped working, let's say Rizapritan. If it does stop working, Sumatritan can work. If it does stop working, Zomaltritan will work or Natriptan. Therefore, triptans are the same as the other painkillers. You can't also have a choice in terms of which one. But the only thing is when the patients have very short onset to peak, abortive treatment will be a nasal spray or injectable. Therefore, the triptan with the nasal spray is Zomaltritan and Sumatritan. But in Kenya, the only one we have is Zomaltritan as a nasal spray. Onset to peak or patients who have severely vomiting, those ones are indicated to use sprays.
Very good stuff, Dr. Mativo. I'm scoring. I'm not seeing any other questions. Anyone else with questions, comments? Okay. There being none, I think I want to start bringing the session to a close. I want to thank.
Doc, we have a presentation by the Novartis team.
Sorry, Peter.
Presentation by Novartis team.
Oh yeah, I had called them out. They didn't. Can we have it? Can we have who
Mantombi, you had a presentation.
Yes.
Yeah.
So it's just will be very short.
Thank you.
Okay. Okay. So thank you again to the KMA team for helping us put together this webinar, and thank you to everyone for actually taking this time to join us this evening to hear out Dr. Mativo speak around migraine and the reason behind prophylaxis as well. So as we were discussing now these latest developments and best practices in preventing migraines, we know that these have a great impact on the quality of life of patients. And so it's very important for healthcare professionals to stay informed about the most effective ways to prevent and manage this debilitating condition. So I'm hoping through the engagements that we've had today, we all have a better understanding of how to help our patients reduce the frequency and severity of their patients. So we as the medical teams are the ones who came together with Dr. Mativo to bring forward this presentation. We are always available to speak further around the topic, speak further around migraines, as well as the preventative measures that are available currently. So a patient aspect is a very important part for us as a team, and it's a very important element in management. So this is why we work very closely as well with our patient safety team, who also have a few words to share for us as well this evening. So over to you, Felix.
Thank you, Mantombi. Just let me share my screen quickly. I hope it's visible.
Yes, it's visible.
Great. So my name is Felix Mochache. I work at Novartis as a patient safety responsible for East and Southern Africa clusters. And ideally, what I do is ensuring that the medications we are having out there are safe to our patients. So my role is in pharmacovigilance. And as usual, every year, Novartis takes part in the celebration of the World Patient Safety Day, which is coming up on the 17th of September, that is next month. And as just part of the celebrations, we decided that ideally we should, as much as possible, sensitize everyone within the healthcare space on the importance of patient safety. Whenever we are promoting our products, whenever we're prescribing our products to patients, whenever we are dispensing products to patients. So that is why I just wanted to speak briefly about pharmacovigilance and why it plugs in and how it plugs in to our practice in the healthcare space. So ideally, as healthcare professionals and as our stakeholders, it's important that we scan and just try to take feedback from patients as much as possible to check on how they are responding to the medication that we are giving them. I think in the presentation, Dr. Mativo alluded to some of the scenarios that you can face, especially with some drugs. Sometimes they can be ineffective. Sometimes patients will experience adverse events, side effects from taking the products. So that is where we are there as the patient safety team or pharmacovigilance team to try and pick out some of these issues. So adverse event reporting is key for us because we pick the result, the data from the market. That is the feedback that you're giving us as physicians. We use it to undertake analysis, that is through collating everything in a database somewhere, try to make sense of any trends that might be negative or might harm the patient at the end of it all. And it's through that we are able to make decisions that sometimes are actually life-changing. So some of you might have received communications from us as Novartis advising on what you need to do in particular scenarios to avoid exposing patients to particular adverse events. It could be a dose reduction, it could be taking care to avoid some drug-drug related interactions. So such kinds of information. So ideally, what you receive is the output of pharmacovigilance, and it stems out of you taking feedback from patients and sharing with us. And that is how we eventually get to have our patients taking safer drugs. So as part of it, I just wanted to play this brief video. Hopefully, you are able to hear the sound. Mantombi, you can let me know if it's audible. Is it playing? Is it audible?
It was playing, but I didn't hear sound.
Is it audible still?
No sound, Felix.
So let me just maybe try share with sound. Probably I didn't share with sound. Let me share my screen. I'll try to play it again. Just let me know if it's audible. Is it audible?
No, still not audible, Felix.
Well, it's a technical hitch. Just give me a minute. I'll try again. It doesn't, or does it?
No, still.
Oh, okay. Maybe it's because I'm joining Zoom through web. Could be the
Okay.
issue, but I think we'll share the slides later on together with the video with everyone.
Yes.
But then the essence of the video is just to demonstrate the importance of pharmacovigilance and just to encourage all of us as um, uh, stakeholders in the healthcare space to ensure that any adverse events, any feedback that is kind of negative, sometimes even positive, is shared with us. And because we use it to make life-changing decisions, to amend prescribing related information, dispensing related information about the products, and that is actually ultimately important in keeping our patients safe. And in line with this year's theme for World Patient Safety, which is improving diagnosis for patient safety, especially having listened to Dr. Mativo, it's important to get everything right from the start so that then we ensure the patients are getting the right treatment, and that will eventually help in protecting them from exposure to unnecessarily medications, exposure to unnecessarily to side effects. And really, we just want to thank you for the journey that you've walked for us so far in ensuring that the medication we are having out there to you and to patients are actually safe. So let's get it right and make it safe from the start. Yeah. Thank you, Ntombi. Back to you.
Thank you, Felix. That is all from us from the Novartis team. We'll hand it over back to you, Dr. Kigondo, to close the meeting.
Thank you very much to the Novartis team. And indeed, patient safety is also key to the Kenya Medical Association mission. And I think the team will work with our CEO, Dr. Brenda Obondo. Maybe they can bring us something on that patient safety day. And with that, before I finish, I would want to recognize the presence of the Kenya Medical Association National Executive Council. We have our CEO, who is Dr. Brenda Obondo, on the line, Dr. Diana Marion, the Secretary General, Dr. Ibrahim Matende, the Vice President of Kenya Medical Association, and Dr. Linda Kemunso, who is our Treasurer General. And just so as not to avoid monotony, I would like to call upon Dr. Diana Marion, if she is able to close for us, and just for us to hear her voice and close this. Dr. Diana Marion, are you able to do that?
Yeah, okay. Yes, I am able to do that, President. So I really want to appreciate this effort. And I also want to appreciate the presenters for actually taking their time and communicating part of the things that we always push ahead. And this is around delivering quality services to our patients. And when we prioritize safety, that becomes a very important thing. So I really want to appreciate the sponsors, Novartis, and the collaborations that you've always had with us. I want to encourage you to continue on the same note, because we change the world by collaborations. So I want to take this an opportunity to also thank the attendees and wish everyone a good night. Thank you.